Acute pancreatitis is usually not a surgeon's diagnosis. Most of the time, it's NPO, fluids, pain control. They go home at the end of the week. That's what we're going to start off with. You do have to know the classic illness script for what is now mild acute pancreatitis. But I'm going to use this lesson, surgical pancreatitis, to explore the Atlanta criteria and spend a lot of time on fluid collection complications. My pun, FCC, poking fun at the Atlanta criteria, FCC, and sort of telegraphing the problem with alphabet soup. We'll get there. And then also want to talk about other times where a surgeon might get involved, infected fluid, and when a surgeon should not get involved, chronic pancreatitis. So to start us off, this is the classic illness script, 0 standard deviations from the mean for pancreatitis. And now I'm adding mild, which I'll define later. This is the type of acute pancreatitis that does not need a surgeon. Pancreatitis is caused by the autodigestion of the pancreas and the peripancreatic fat by inappropriate early activation of pancreatic enzymes, zymogens. There's a bunch of reasons why that shouldn't happen: bicarbonate-rich fluid, flushing the zymogens, activation of the zymogens in the duodenum. But if something goes wrong and trypsinogen is activated to trypsin, it activates all the other zymogens no matter where they are. They degrade lipid and protein, aka cells. You end up with pancreatic liquefactive necrosis and peripancreatic fat necrosis. The most common reasons that this occurs is alcohol and obstruction by gallstones. There's a long list and details of mechanisms we're going to cover in internal medicine, but here you should know alcohol and gallstones, and then others of import like familial hypertriglyceride demia, iatrogenic from ERCPs up to 30%, and drugs. I'm going to leave that one vague because most of the drugs that cause pancreatitis either aren't used anymore, or the ones that thought would cause pancreatitis, like GLP-1s, end up not causing it that often. For the mild form, the patient is going to present with epigastric pain that bores to the back. Made worse with food, and is accompanied by nausea and vomiting. And the pain is so bad with food that the patient knows not to desire anything, presenting with a lack of appetite, anorexia. The diagnosis is made with 2 of any of the following 3. The classic epigastric pain, an elevated lipase that is at least 3 times the upper limit of normal, or evidence on CT, which will show peripancreatic fat stranding. The dark gray mesentery surrounding the pancreas is lighter gray. Now, I'm not going to spend too much time on this here in the surgical pancreatitis lesson, but the point is that if you have the classic syndrome and the lipase, you do not need to get the CT scan. Getting the CT scan isn't dangerous, especially now that we have low-dose CTs, but the problem is down the line. If someone develops symptoms of a pancreatitis complication Having a relatively normal CT scan from admission may make that person less likely to repeat the scan. It's not bad to do, you just don't have to do it. So if you have one of two of three, number 1 and number 2, don't do the CT scan. With mild pancreatitis, the treatment is bowel rest. Keeping the patient well hydrated with intravenous fluids, correcting electrolytes, and using patient-controlled analgesia. With intermittent bolusing, the patient is going to have peaks of opioids and be passed out, and valleys and be in lots of pain. We know this is going to take a couple of days to resolve, so turn on a basal rate and let the patient push the button themselves rather than waiting for the nurse to get back to them. You can also monitor their pain control, because if they didn't push the button at all, they can go down in the basal rate. If they're mashing on it all night long and not getting their dose, increase the basal rate. And then start clear liquids when the patient is hungry. The patient will respond the way the patient does. Early, late, not beneficial. If you start too soon, you incite another bout of pancreatitis, reset the clock. Have them wait till they're ready to eat, that is, they're hungry and free of pain. And then escalate slowly. These patients usually discharge within 7 days. And of course, I don't want to completely skip it, but in part of the admission, there might be the workup for a reason why they had acute pancreatitis. For example, a right upper quadrant ultrasound might be gotten to rule out stones, which would need further evaluation with MRCP. Or a CT scan might prove evidence of a lesion, which would also need an MRCP and potentially a biopsy. Right, so these things are present. They're not done every time, but I just want you to be aware, since I'm hand-waving over this illness script, which I cover in detail in the medicine videos. That is the standard illness script for acute pancreatitis. Enter the Atlanta criteria. 5 features, the first of which is severity, where mild came from. Now, of course, like everything I do, the Atlanta criteria are slightly more difficult than I'm making them, but I want to simplify them so that you can see why they're doing what they're doing and what it communicates. There are 3 levels of severity: mild, what they call moderately severe, which is silly because it's moderate, and severe. To get these categories, 2 criteria: the presence or absence of organ failure, and organ failure the way that is defined by the criteria, not the way you'd expect. It's a scoring system. So I don't want you to calculate the score. Just know that there is a table you can look at to determine, are they in organ failure? It looks at cardiovascular, pulmonary, and renal. And is there the presence or absence of a fluid collection complication? Remember, that's my term. And based on the severity, you can predict the outcome. To be mild, I didn't put it over here because it's not part of the usual illness script, but it is part of the Atlanta criteria. There must be no organ failure at presentation and no development of a fluid collection complication. As we just said, the outcome is discharge within 7 days, no long-term problems. Moderately severe, moderate, has organ failure at presentation, but it lasts less than 48 hours. Or they had no organ failure, but developed a fluid collection complication, or both. This patient is going to have significantly increased morbidity. It takes a long time to deal with fluid collection complications of pancreatitis, but they have almost none of the mortality seen by the severe severity. To be severe, you have organ failure at presentation, and it lasts for more than 48 hours. And by definition, you're going to end up with a fluid collection complication. This has increased mortality. Leaving the hospital is unlikely. And that tracks, right? Someone comes in with severe sepsis and they respond to fluids, they do better than someone who's in septic shock who by the third day is still on 4 pressors. That person's not likely to do well. So this is not foreign, but it's now specific to that Atlanta criteria, how do you calculate organ failure, but the idea is there. No complications, leave. Some complications, you got to deal with that for a long time. That's unlike most other conditions, but okay. And if you come in really sick and you don't get better, chances are it's not going to get better. Fine. 2 is morphology, which tracks with 3, phase. Because phase is used in early and late phase of fluid collection complications, I get rid of this and just say, is it 7 days or not? And this is a little bit of a cheat. Day 0 is defined by symptom onset. Then at 7 days, the early phase is over, and from 7 days on, there is the late phase. I reserve phases for the fluid collection complications, and I borrow what they mean. The phase means the first 7 days is incredibly inflammatory. Pancreatitis is as inflammatory as gram-negative bacteremia. Leaky capillaries everywhere. That's other complications we'll get to. But it's also radiographic. Radiologists are trained to not call morphology in the first 7 days. It happens to coincide with the 7 days of the inflammatory early phase. The reason they're not supposed to call is because edema and necrosis are both dark gray. The difference is, in edema, the edema will go away. If the edema resolves, the normal pancreas will be revealed. And that means there was no necrosis, so the morphology is termed acute interstitial edematous pancreatitis. On the other hand, if after 7 days the dark gray does not resolve and the normal pancreas doesn't return on imaging, that is necrosis. Necrosis will not resolve. And if there's any evidence of necrosis, it's no longer acute interstitial edematous. It is now necrotizing pancreatitis. There is going to be the desire to put the mild form on acute interstitial edematous and the more severe form on necrotizing pancreatitis. The green one's better than the red one, but they don't line up with green and red. More often than not, necrotizing is the one that's worse, but they do not perfectly overlap. So know that this is only morphology, although there's definitely a trend for interstitial edematous to be more mild and necrotizing to be more severe. Trend, but not overlap. The 4th is the presence or absence of fluid collection complications. Here's why you see the FCC pays off. Thankfully, it is a convoluted concept, but it actually just comes down to being a certain age and affiliated with the morphology. On the y-axis, phase. The early phase of a fluid collection complication is if that fluid collection complication is less than 28 days old. In the early phase, there will be no inflammatory rind, and on imaging, therefore, no enhancing margin. In the late phase, from day 28 on, there should be a rind, and therefore on imaging an enhancing margin. Now, it's not like the rind and enhancing margin magically appear on day 28. The point is, the older a fluid collection complication gets, the more organized it'll be, the more of an inflammatory rind will be formed, the better contained the fluid will be. 28 days. 28 days, along the x-axis is morphology. First column is acute interstitial edematous. Second column is necrotizing. Becomes a 2x2 grid with alphabet soup. If it is an early fluid collection complication, it is given the adjective acute. And then, seemingly without rhyme or reason, the rest of the words. Acute, pancreatic fluid collection. Abbreviated APFC. If it's late and acute interstitial edematous, it is given the name pancreatic pseudocyst. This replaces any form or version of pseudocyst. Essentially abandoned all subtypes and said, this is the one pseudocyst. Abbreviated PP. For necrotizing, it's an acute necrotic, not fluid collection, just collection. Abbreviated ANC. Late necrotizing is called a walled-off necrosis. Abbreviated WON. It's not hard, it's just not immediately clear because necrotizing, necrotic, necrosis, different tenses, but it all lines up color-coded. And I think that this is the major section where a surgeon participates, so I actually want to spend a little bit more time on this. The pathogenesis is such that pancreatitis is intensely inflammatory. First 7 days, leaky capillaries everywhere, free fluid goes everywhere. And this is unlike free fluid in transection of bowel. The fluid itself is not infectious. So the free fluid is going to organize because of the immune system, forming an inflammatory rind. That inflammatory rind takes a lot of time to form and is essential for structure. I like to use the water balloon example. Imagine you take a bucket full of water and put it on the table. You can put a needle in that water really easy, but if you let go of the needle, it falls over. There's nothing to stabilize it. If you took a water balloon and filled it up at the faucet, you could tie off the end of the water balloon and carry it with you. If you put a needle into it, you could let go. It might drain the water, but the balloon holds onto the needle. If you got a really thick water balloon, you could put a bigger needle in and let go of the needle and it would still remain in the water. The inflammatory rind is the water balloon. And I like this example especially much because rather than go to the tap and put the water in the balloon, the immune system has to take the balloon and try to scoop up all the water in the bucket. It takes a long time. The point is, in order to get anything into that fluid, in order to drain it, you need to have structural support, that rind. And so the patient you should suspect fluid collection complication in is someone who gets an asymptomatic CT because they had at